Hi, I'm Jessica Fay. The objective of this presentation is to explore how Fick's law governs physiological gas diffusion, both within the lungs and across biological membranes, as well as its contextual application in the perioperative setting with volatile anesthetic uptake, distribution, and patient safety implications. Fick's law describes the rate at which a gas diffuses across a membrane. The diffusion rate, or V gas, is directly proportional to surface area, the partial pressure gradient, and the diffusion coefficient of the gas, and inversely proportional to membrane thickness. Rate increases with large surface area, high partial pressure gradient, or high gas diffusion coefficient, and decreases when membrane thickness increases. This equation forms the foundation for understanding gas exchange in both normal physiology and anesthesia delivery. Gas diffusion in our lungs reflects all variables of Fick's law. A healthy alveolar capillary membrane has a large surface area and a very thin membrane, allowing efficient movement of oxygen, carbon dioxide, and anesthetic vapors. Every gas has its individual diffusion coefficient, primarily dependent on solubility and molecular weight. CO2 diffuses faster than O2 because its high solubility gives it a much greater diffusion coefficient despite its heavier molecular weight. For inhaled anesthetics, the alveolar partial pressure is the principal driver of diffusion into blood and across the blood-brain barrier until partial pressures equilibrate. Ventilation and cardiac output modify uptake. Increased ventilation raises alveolar partial pressure and speeds diffusion, while high cardiac output can slow the rise in alveolar pressure because more anesthetic is carried away into the bloodstream. This diagram illustrates the application of Fick's law across both the alveolar capillary membrane and the blood-brain barrier. In both systems, gases move from higher to lower partial pressure across a membrane with defined surface area and thickness. Pulmonary edema, fibrosis, or emphysematous alveolar loss reduce surface area or increase membrane thickness, diminishing diffusion in the lungs. The blood-brain barrier can also become thicker or less permeable with inflammation, chronic hypertension, diabetes, or aging, slowing anesthetic diffusion into the CNS. Conversely, trauma, hypoxia, or osmotic therapy may temporarily increase permeability. These physiologic changes influence how quickly volatile anesthetics equilibrate with the brain. Inspired and alveolar partial pressures determine how inhaled anesthetics diffuse into the bloodstream and the brain. The rise of alveolar partial pressure, or FA, relative to the inspired concentration, FI, reflects Fick-driven diffusion towards equilibrium. Agents with low blood gas solubility equilibrate quickly because the blood cannot dissolve much anesthetic, so arterial pressure rises rapidly to match alveolar pressure. These agents, such as desflurane and sevoflurane, produce fast induction and rapid emergence. Highly soluble agents like isoflurane dissolve extensively into blood before arterial pressure increases, delaying the rise in brain pressure. This slows both onset and emergence because more anesthetic must leave the tissues and bloodstream before pressure falls. Fresh gas flow influences this process. Increasing fresh gas flow raises Fi, speeding the rise of Fa and strengthening the driving gradient. Lower free gas flow slows this. Equilibrium occurs when alveolar, arterial, and brain partial pressures are nearly identical, creating a stable anesthetic depth. Nitrous oxide demonstrates several clinically important diffusion phenomena. Because nitrous oxide is about 34 times more soluble in blood than nitrogen, it diffuses into closed gas spaces much faster than nitrogen can diffuse out of the cavity and back into the bloodstream. This can rapidly increase volume or pressure in a pneumothorax, middle ear, intracranial air pockets, bowel obstruction, or the cuff of an endotracheal tube. For this reason, nitrous oxide should be avoided whenever trapped gas may be present. When nitrous oxide is discontinued, a reverse diffusion gradient occurs. Nitrous oxide leaves blood rapidly and enters the alveoli, diluting alveolar concentrations of oxygen and carbon dioxide and causing transient diffusion hypoxia. Giving 100% oxygen for several minutes prevents this. The principles of Fick's law are also utilized during cardiopulmonary bypass. Oxygenators are engineered to maximize surface area and minimize membrane thickness to maintain efficient diffusion of oxygen, carbon dioxide, and volatile anesthetics when the lungs are bypassed. This scenario exemplifies Fick's law, illustrating desflurane uptake during acute pulmonary edema. Using a partial pressure gradient of 200 millimeters of mercury and the equation diffusion rate is equal to diffusion coefficient times surface area times delta P divided by thickness, the calculated diffusion rate under normal conditions is about 140 milliliters per minute. When pulmonary edema reduces surface area and doubles membrane thickness, the diffusion rate falls to about 50 milliliters per minute, or roughly one-third of the original value. Clinically, this means changes in vaporizer settings take much longer to affect brain partial pressure, increasing the risk of inadequate anesthetic depth unless managed proactively. Understanding how Fick's law governs gas diffusion has direct patient care implications. Diffusion-limited diseases slow anesthetic uptake and require adjustment of agent choice, fresh gas flow, and ventilation. Nitrous oxide must be used with caution as it can expand closed gas spaces and cause diffusion hypoxia. Solubility determines diffusion, determines how quickly anesthetic depth changes. Desflurane and sevoflurane provide rapid control, whereas patient response to isoflurane is slower. Ventilation strategies such as increasing inspired oxygen, applying PEEP, or treating pulmonary edema help restore diffusion efficiency. These principles guide safe anesthetic delivery, prevent complications, and support precise control of anesthetic depth. Thank you for coming to my TED Talk.